Hey everybody, I'm back. So for the group that was with me in class today, the last few slides, I don't know what happened to the recording on that, so you may have to sit through a few of these over again one more time. All right, so to pick up where we left off from part one, we're now talking about cardiac resynchronization therapy, or CRT, which is biventricular pacing. So if we have a heart that doesn't conduct electricity very well, and we want to keep the left and right ventricle working together and time them the right way for maximum pumping, then we will put it in. This is just a special pacemaker, and it's for patients who are, despite all the medical therapies that we can give them, are still symptomatic, and it's meant for people with a very severe heart failure or left ventricular ejection fraction of less than or equal to 35%. Okay, and they can also have an ICD in that as well, just like other pacemakers. So if they have, a propensity for going into VTAC or VFib, then this can also shock them out of that. Okay, so it's a new therapy. It helps with ventricular desynchrony. So hearts that even the ventricles may not be even able to communicate with one another. Okay, there are the leads. Sorry. Going to so you'll see the one lead hitting the sort of in the SA node area. That's kind of a cool picture though. And then there's a big lead going to the right ventricle, and you'll see the other lead kind of poking out the side going to the left. Okay, so what is ICD therapy? So ICD therapy is when we need to actually apply some electricity to the heart while it's from an implanted device. So it consists of pacing, cardioversion, and defibrillation therapies, and that can treat a Brady or a tachyarrhythmia. So for a Brady, it just introduces another impulse and the heart goes and runs with it. And sometimes we can override a fast rhythm by producing a stronger impulse than what's already in the heart. Excuse me. All right, so an external programmer is used to monitor and access the device parameters. So we don't have to cut the patient open every single time we want to make an adjustment to their internal device. We can just, go onto a computer, it communicates, and there are even apps for some of these things now. So they go into the chest wall beneath one of the clavicles, right? And the ICDs are really first-line therapy for VTAC, VFib patients. So those are the only two. Remember when we talked about this earlier, the only two rhythms that are actually shockable are VTAC and VFib when we talk about a lethal arrhythmia. So just like defibrillating a patient who's died and doesn't have a pulse, and we're going to shock them for that pulseless rhythm. If someone goes pulseless, has VFib, and they have an implantable device, the same thing's going to it. The device is going to fire off and hopefully shock them back into a sinus rhythm. It also can be used for treatment of atrial arrhythmias, though. So if you have somebody that frequently goes in and out of, like, say, a rapid AFib or an SVT, then it can be programmed to intervene and actually apply a little bit of electricity. Okay. Cardiac resynchronization therapy for heart failure, that was the slide before. And they're smaller than they used to be. So small incisions, local anesthesia, very short, sometimes even like a 23-hour stay. Not the same stuff like the old, I was saying that to the class today, the old devices, the big old pacemakers used to be like the size of a carton of cigarettes, which, by the way, is probably why they needed it in the first place for their heart disease. Okay, battery longevity is up to 9 years. You can have single or dual chamber therapy, and this is done quite often nowadays. All right, so here's another picture. So we have the atrium, the ventricle, and then we have the duals, right? Okay, and that's the the automatic one, the fully implanted device, right? Patient may also receive antiarrhythmic medications. If they need an implanted defibrillator and it's going off, then they probably are going to be on something that will help control that, like amiodarone. Okay, so the amount of joules, when I do external, like if we're doing ACLS, if we're doing an external defibrillation, the joules are much higher. They're, you know, 200 joules. Whereas if the actual electrode is right next to the muscle itself, we need a much smaller amount, so 25 to 30 joules. It can shock them up to 4 times. Patients may feel faint, short of breath. Patients feel it. Okay, this isn't like a, oh, I was asleep and my, defibrillator must have. No, patients feel it. They should be taught to feel a thud, a jolt. Okay, and they should avoid magnetic fields. We actually use a magnet to shut these things off. So no MRI for them. And their families should be taught to do CPR. Sick sinus syndrome. So this is the main reason why people end up needing a permanent pacemaker, the number one reason. So what happens is we all know we have our SA node, and that's the intrinsic pacemaker for the heart. And what can happen with that is, we don't all stay young forever, and it can become problematic. So what happens is the SA node continues to fire, but it doesn't fire at its normal, steady pace. So it'll go really, really fast and then really, really slow. They call that the Brady-Tachy syndrome. And it is a sinus rhythm because all of the QRSs are preceded by a nice, happy little P wave. It's just the rhythm isn't the way that it used to be. So alternating periods of tachycardia and bradycardia accompanied by sometimes a long sinus pause, like of a couple of seconds. So if you have a bradycardia and a pause, then you can have syncope, right? So we're losing cardiac output. We can have fatigue, forgetfulness, and causes, an older, sick heart. So as people age, coronary artery disease, SA node trauma, neuromuscular disorders, rheumatic fever. Okay. So acute. So if this rhythm is causing impaired cardiac output, then they will put, and it's affecting the patient, quite a bit. They'll do a temporary pacer until they fix the reason, or if they determine that the patient does need a permanent one. If it's chronic, we're going to try and treat it with digoxin, and then a pacemaker. And it is the most common reason why patients receive a permanent pacemaker. So what happens is it all looks like sinus. We have a P wave, we have a QRS, but the rhythm is not regular and it speeds up and slows down. Here we have the atrioventricular heart blocks, or AV blocks. So that's a delay or interruption. So I was telling the day class today, so in our heart, we have our SA node, and then the next it's called the junction, the conjunction junction. The junction is the AV node before it starts going down the septum and, through the bundle branches into the Purkinje fibers. So that AV node is sort of like a delay switch. So we're supposed to have atrial conduction and then ventricular conduction with an associated, first the atria contract and then the ventricles contract. So we need that timing to work out, and that's what the AV node is for. Well, if the AV node doesn't work very well or it stops working altogether, we can have an AV block. Okay, so ischemia or damage to the area, they had an MI, rheumatic heart disease, and anything that could cause problems with your heart can cause an AV block. Hyperkalemia or DIG toxicity can also do that as well. Overdosing on beta blockers, anything you can think of that can cause a heart problem can cause an AV heart block. So the first one is called, and these increase in severity, just remember the old burn, we'd have 1st degree, 2nd degree, 3rd degree burns, and the higher up you went, the worse the burn. Well, same thing with heart block. So 1st degree is meh. This is just really a delayed conduction. So the AV node is taking a little too long to let that, conduction through. And it's a PR interval greater than 0.20. For instance, in this one that's on the screen, they have a PR interval of 0.26. But anything greater than 0.20 or one large block is considered a 1st degree heart block. Okay. we look at our patient. If our patient is symptomatic, then we treat it. If our patient is not symptomatic, then we watch. This is not a life-threatening arrhythmia in most cases, not even, it's just a heart block. It's usually considered normal sinus rhythm with a first-degree heart block. That's how we would document this. All right, now we have second-degree heart block. So two different doctors, Dr. Mobitz and Dr. Wenckebach, both claimed fame to this one and named it after themselves, or it was named after them. It's second-degree heart block type 1, also called a Mobitz 1 or a Wenckebach. This one loves to confuse students. So this one has 3 different names. Second-degree heart block type 1, which I like to think of as the generic name, or it's called a Mobitz 1 or a Wenckebach. All right, so this one can be called going, going, gone, or walking away with them for a Wenckebach. So what happens is there's an increase in the PR interval. So if you look at the first QRS complex, you'll see there's a P wave right in front of it, a normal QRS, a T wave. And then if you notice, the next P wave is slightly farther away from the QRS. Go to the next QRS complex, you'll see the P waves even farther away. And then the next one, there's a dropped QRS complex. So what's happening is a gradual increase progressively in each PR, and then we lose a QRS complex. Remember, when we lose a QRS complex, we have lost systole. So we lose a beat, we lose cardiac output. All right. So treatment, eliminate the cause. I had a patient, multiple patients that go into blocks for all types of reasons: medication, or they just had anesthesia, or their electrolytes are off. So we're going to, especially if we get to a second degree or higher, we're definitely going to be investigating this. So they're going to have an EKG. They're going to have their electrolytes drawn. We're going to make sure the doctor comes and sees them. We're going to do a full assessment. Are they having any chest pain? Are they short of breath? Is their blood pressure okay? A full circulatory assessment. Okay. Next is a type 2. So second degree heart block type 2, also called a Mobitz 2. All right, so what this one's a little scarier. We're moving up towards a 3. Remember, the higher the number, the worse off we are. What's really scary about this is you don't see it coming. So you have a normal P wave followed by a QRS, and then the next, we have a normal P wave but no QRS. And you can lose multiple beats in a row. You don't see it coming. And this can quickly progress to something scarier. You're on your way to a complete heart block. All right. Just of note, if you look, when the P and QRS are together, they're always the same. The PR interval doesn't vary. So we have, whatever the PR interval should stay pretty stable when there is an actual QRS. That's what's so scary about this. So you never know when the QRS isn't going to show up. Okay, and this may progress to a higher block. All right, if the patient is hypotensive, then we may give them medication or even temporary pacing. Okay, so now we're going down the conduction highway and past the AV node, and we're going to get to the bundle branches. And a bundle branch block is basically what it sounds like, is there's a block in conduction. So what happens is that the energy will go around the blockage, and so on the QRS you'll see, sometimes they call it a notch or rabbit ears on some of the QRSs, and it just shows that the energy had to go in a different route. It also slows conduction, so you can causes an MI or valvular disease or congenital abnormalities, and we want to treat the cause, and we want to make sure that this doesn't cause a complete heart block as well. So junctional dysrhythmias, we just talked about the AV node. And if the SA node fails to fire, or sometimes the AV node can take over. So what happens is, instead of it being sinus rhythm, it's an AV node or junctional rhythm. So the junction is what's firing the impulse in the atria. So technically the AV node is in the atria. So you're going to have a tiny little, maybe a P wave, but a very short one, and a narrow QRS complex. So this can be hard to pick up for new students or people new to this. What's different is whenever we're diagnosing sinus rhythm, or interpreting, I should say, sinus rhythm, we're always looking at a lead 2. So for something to be sinus rhythm, we look in a lead 2, and we want the P wave to be upright between 0.12 and 0.20 seconds from the QRS, a normal upright QRS complex followed by a T wave. In a junctional dysrhythmia, you will see that the P wave may be inverted. It may actually occur after the QRS, or it may be embedded in the QRS. So sometimes it's either a missing P wave with a narrow QRS complex, an inverted, or one that's too short, so it becomes before less than 0.12 seconds from the QRS complex. The normal escape rate for a junctional rhythm is between 40 and 60 beats per minute. So it can appear, it almost looks like a sinus bradycardia, but if you look at the P wave, you'll see the P wave doesn't look normal. So if you look in on the EKG to the right here, if you look in a lead 2, you'll see that the P wave is upside down or inverted, and that's what tells you that this is a junctional rhythm. Okay. Now we have paroxysmal supraventricular tachycardia. So SVT just means that the impulse is generated above the ventricle, so we're going to have a narrow QRS complex. Paroxysmal just means that it comes and goes. So this patient may have occasional bursts of a tachycardia, and this can be anywhere from 100 to 300 beats per minute. If it goes greater than here it says 180, in some textbooks it says 160. It may result in decreased cardiac output. All right, so this is a re-entry tachycardia. All that means is that the energy starts going in a circle, and that circle triggers a QRS complex, and therefore systole, and it goes around and around and around and around and around. So this is an SVT, so we can treat that with adenosine, or if it's not emergent, the patient's doing okay. Otherwise, we may have them try vagal maneuvers first, or we can cardiovert them. So if the patient's severely compromised, sometimes we go straight to the cardioversion if the patient's unconscious, that kind of thing. So this is a mnemonic, so the AEIOU plus D. All right, so if your patient is having an arrhythmia, use the mnemonic to look for contributing factors. So A is autonomic nervous system, right? So if they're having a tachycardia, for instance, check for pain, anxiety, and stress, all right? Lower abdominal pain increases vagal tone. So if your patient's having a lot of abdominal pain, that may actually cause a bradycardia, all right? That's the sympathetic response, okay? We also want to watch for acidosis and alkalosis. Electrolytes. So we know a normal potassium is 3.5 to 5. If you keep for a cardiac patient, you want to keep it above a 4, all right? Calcium, 8.5 to 10.5, and magnesium, 1.6 to 2.2. If you have a cardiac patient, you want to keep that just a notch higher. Ischemia, injury, and infarct, okay? So if a patient is having some kind of oxygenation issue to their own cardiac muscle, you will see EKGs changes, and most notably in the ST segment, the T wave, and something called a Q wave, all right? Dysrhythmias, all right, so especially ventricular in nature, are commonly associated with acute myocardial infarction. So that's why we always, if we have any kind of change from the patient's baseline rhythm, we will get a 12 lead, because a lead 2, if they're on a cardiac monitor, really only tells you one small part of the story, and we want to see what's going on in the rest of the heart. O for hypoxia, right? We want to keep their pulse oximetry at least 92%, and hypoventilation. Okay, so if a patient isn't breathing very quickly, like some of our sleep apnea patients, or if they've had opiates, for instance, they can retain CO2 and become hypoxic. Unhealthy hearts, okay? Heart failure, valvular disease, cardiomyopathy, renal disorders, right? What does that do to your potassium levels? Hypertension, pulmonary disorders, okay? Any other comorbidity like diabetes. Ooh, we know that's one of the huge ones in this population. And drugs. So drugs can do a doozy on your cardiac rhythm. So anything that we give for hypertension or to treat heart failure can cause a dysrhythmia. So digoxin, beta blockers, any of the antihypertensives, antiarrhythmics, okay? And the toxic effects of drugs are related. So you have one, for instance, like we were always talking to you guys about furosemide and digoxin. So if your patient's getting both, then you definitely need to check their potassium levels because they can precipitate each other. And it's a common combination. So you need to make sure your patient isn't hypokalemic and they're not becoming dig toxic. All right, so a quick review. The automatic internal cardiac defibrillator is used for ventricular and atrial arrhythmias. We can do biventricular pacing, and that's used for those severe heart failure patients. And just make sure you're mindful of what's going on with your patient situation. If you have someone who's getting multiple blood transfusions, we know that all of that can affect not only calcium but potassium. If we have a postoperative patient who has a cardiac history, know that all anesthetic agents are going to have some effect on cardiac conduction, which is why patients are recovered in a recovery room on a monitor. All right, so just be very mindful of what's going on. The patient's central perfusion is at stake. So if their central perfusion goes, then that's the end of the game. All right. I'm also going to pull up in a separate PowerPoint. I'm going to go over the heart blocks again, just using a different PowerPoint.